All right, so we're back, and we're going to finish up the EKG series. Then we're going to be redoing the earlier EKG series. But for now... We have to, because our new format.
Yeah, we have to.
We're going to do this wildcard section. And the first one up on the wildcard is the Scarbosa criteria. I love the Scarbosa criteria, actually.
Can I talk about Scarbosa criteria? Because
I would love it.
I'm not very smart to talk to about Welland syndrome. So I'd like to be able to talk about Scarbosa. I want to talk about things that I know about. First off, when I do this lecture in CEP, whether it's good, whether it's bad, or whatever, the first thing I do is I take out the two words concordance and discordance.
I know, because people don't understand that.
No, I hate that.
Like same side, other side.
You're darn right.
Yeah, I don't know why they use it that way.
So, and I always say, like, same chicken wing, just because, me and you both love chicken wings. Oh. You being from Buffalo, yes. we love chicken wings. But getting back to the Scarbosa criteria, I think that's why a lot of people, they turn their heads at it because of these terms that these cardiologists come up with and physicians such as you.
Right. Just say same side, other side.
And that's what's important. Concordance is actually the significant factor when we're talking about Scarbosa.
Right.
Why are we applying Scarbosa criteria to even begin with, though, is your left bundle branch morphology or your pace rhythm, right?
Right.
Those are the two reasons that we would even be referencing Scarbosa, right?
That's correct.
No other reason.
No.
All right. And then there's the modified Scarbosa. I'm typically, I'll let you kind of go into that because you brought up some research on that as well. And I have it pulled up here for you.
Yeah.
Because you told me to pull it up. But when we think about why we're actually talking about Scarbosa, first off, we have a patient that maybe presents with acute coronary syndrome, and you go out and they're a left bundle branch on the monitor, and you're like, what do I do now? I can't call this in the field.
Right.
But what can I know more about the patient? You absolutely can know more about the patient. It's often difficult to identify an MI for patients with existing left bundle branch block.
That's right.
Now, new left bundle branch block, that's a whole different story.
Right.
But about 1 in 200 patients with MI have a left bundle branch block, which I think is...
And how many people really know if it's new or not? I mean, there's some people that, just haven't been to a doctor in 30 years.
Well, even when we did this talk before on left bundle branch morphology, when I asked, or I told you I always ask the patient, do you have a history of a left bundle branch? And you were like, are they really going to be able to tell you that? Some can, some can't.
Right. And then I found out that the latest research on that actually just shows that, cardiologists don't weight that as heavy as they used to. Which is interesting, but...
Scarbosa or new onset?
New left bundle.
Oh, okay.
But anyway, go ahead.
So then we get to our Scarbosa criteria. We're talking about concordance. Concordance is the most significant thing that they're going to have, that you're going to see. And again, that's just the QRS is up, they have elevation.
Yeah, if you can bring up a picture...
don't have a picture, but we'll put the one on the screen.
Yeah.
Let me see if I could Google this really.
It should be further down on that page, isn't it? No.
Nope. If you want to talk while... the one thing that I did want to say, reference to Scarbosa, is the concordance that they present with, you don't have to have a lot of that. You don't have to have a lot of that. If you have concordance somewhere in those particular leads, and
I think what it'd be easier just to say it like concordance or discordance, meaning does it cross back the midline or not? That's really my question. If it doesn't cross back the midline, like the complex doesn't come back down over the midline of the EKG and back up into whatever, and it stays up, that's abnormal, and that's considered a STEMI equivalent.
So this is what I use when I'm teaching this, just because I think that this right here, they're basic terms or whatever. So this is what I use. If you kind of like this, you can hold on to this. Sorry about the pop-ups. But yeah, right here, and then there's a
and if we show the picture up here where they try to go through the concordant and discordant thing, basically it should cross back over the midline, right? If it stays elevated, meaning it stays above it doesn't cross back over, it stays up, it's elevated and it's considered a STEMI.
Yeah.
If it goes down and doesn't come back over but stays down depressed, it's considered a STEMI.
So right here, go right here. You look at this one right here. This is the most important finding. This is the most significant. This right here
is not as significant.
But let's talk about that one though right there. Why is it even part of the scarbosa? Because this right here is inappropriate discordance. Does that make sense?
Correct.
Inappropriate discordance, meaning this discordance right here, because all left bundle branch blocks are going to present. Yeah.
Right.
Present with discordance. And when we talk about inappropriate discordance, this elevation is way different.
Meaning it's greater than 5 millimeters.
Right.
It's high.
Right. Yeah.
I think the best thing we can do for the viewers is show examples of it. Mm-hmm. And probably this one's pretty good. You see that this one is discordant. It goes down. Mm-hmm. It stays down. It goes down, it stays down. Like, that's abnormal.
Don't forget, though, to talk V1, V2, V3 are very specific leads that we look at. Scarbosa as well. I would always, when I was in paramedic school, especially when they're throwing these terms out, like just concordant. I mean, the term scarbosa already in itself is weird. But then you throw these... It's
a doctor's name.
Yeah, but
you know that's what had to happen there. There's an abnormal concordance there. Do you see it? It stays elevated. In example 3, example 4 stays down, and this ST elevation that you normally would see is huge.
Inappropriate
discordance.
Discordance. Well, I didn't come up with that, but I did read it.
No, it makes sense. So we'll put examples of this on there so everybody understands exactly what we're talking about. But I'm telling you, the Scarbosa criteria is a big deal.
So you like the fact when the paramedic comes in and says they're a left bundle, or they call you, because they're going to call you. Because if they're thinking this patient's having a STEMI, they're going to call you. They're going to go ahead and send that 12 lead, and they're going to tell you, hey, we have this patient that presents pale, cool, diaphoretic already. I don't really care what the EKG says, has my attention. And they say, we applied Scarbosa criteria, and they come out with a Scarbosa score of 8. You're like, bring them here, and let me call your supervisor.
Right. I don't even care what the score is. You just told me you applied it, and you found positive findings.
Yeah.
All right. Look at Elena Scarbosa. She's a female doctor.
Did you go to school with her?
No, but that just blew your mind, didn't it, that it was a female physician? Anyway.
Did you cheat off her paper?
All right, let's talk about Wellens. I've actually had one case of Wellens.
I pulled this up for you if you want it.
That'd be great. Mm-hmm. So, Wellens syndrome, actually, when you actually bring it up or find it, sometimes the cardiologists are less than impressed, but it's actually very interesting. It really is kind of specific, or they say it's specific, for a high-grade lesion at the LAD, at the top of the LAD.
Sorry if this is creepy, but I'm learning, because I don't know nothing about Wellens.
Oh, but you've definitely seen it when I tell you this. So, there's a Wellens A and a Wellens pattern B. I would say the one that people know the most is pattern A, which is a biphasic T wave. I have an interesting story to tell you about this, and I'll try to find it for you guys, and I'll send it to you if I can find it. So, chest pain patient, you take an EKG, and you see in V2 and V3 these biphasic T waves. That's supposed to be like I'd say like a TIA of the heart. Does that make sense? Like tap, tap, hey there.
Something's going on.
Something's happening here. So
one thing I was going to ask you, they say a lot of times when the patient actually has Wellens syndrome, by the time EMS gets there, their chest pain's resolved. Is that?
It can.
Okay.
Yeah, cool. It is a high risk. You are high risk for an acute MI in the next weeks. Okay, so this, like I said, a TIA of the heart.
Warning sign.
It's a warning. So there's also a pattern B, which is a deeply inverted T waves. Now, you could have deeply inverted T waves for other things like PE and stuff, but this is something concerning. Mm-hmm. I had a lady at Hillcrest Hospital who was status post knee replacement 6 months previously. She had an EKG to clear her. Her EKG was cleared, medically cleared. She had knee replacement. She did fine, and she was coming in with chest pain, and she had positive troponin. Anyway, she had almost 100% LAD. She had Wellens on her EKG and had Wellens on the EKG for her pre-op clearance.
I thought you were going to poke me.
Anyway, so Wellens syndrome, very interesting. Something to look at. It's very easy. V2 and V3. Deep inverted T waves is Wellens B. but really those biphasic T waves are abnormal.
We'll put that on the screen too. That you really just got to see it, but we'll put that on.
That's good.
Yeah. I told you I wanted to talk about Scarbosa because I didn't know much about any of these other things except for the next one we're going to talk about, and that brings us to that. Unless you have more to talk about Welland.
No.
So WPW, Wolf Parkinson's White. Particularly in the field, why this is important to us, because if it is something we're going to treat, meaning the tachycardia that we're going to treat that's symptomatic, we probably don't want to be treating with a calcium channel blocker. We want to withhold that diltiazem. So that's the clinical relevance of being able to identify WPW. Delta wave, right?
Right, and usually people know they have it. Now, I can try to look for one other EKG of a pregnant lady that passed out at Walmart.
I got one right here.
Do you have one?
I know a guy that actually has
it. Anyway, I diagnosed WPW. They couldn't believe it because a lot of the time they'll argue with you about it, but the delta wave was on there. It was very clear, and she came into the hospital. They ended up putting her, getting her treatment.
Yeah, this guy right here, he, and that way you can kind of look at it how.
Oh, yeah.
So, I mean, you're like, oh, yeah, I see that. I'm going to tell you right now, as a paramedic.
No, it'd be hard to see.
If you don't mention that to me, I may miss it.
But that WPW, and if you pull it up on there, you can even see it. That delta wave, the problem with WPW is you can go into these tachyarrhythmias, and that's what ends up happening, is that you get this excitatory state. You have to be careful what you give them.
You might need to eat. Sorry.
You got to be careful what you give them because you don't want to. You have to be careful what you want to block the accessory pathway, but not all of the pathways. So,
what I was going to say is I'm all about identification. When I look at a 12 lead, I'm all about identification. I love definitions. That's why I always like to break down sinus rhythm. P wave, QRS, T wave.
Yeah.
I like to break down atrial fibrillation.
That's still how I do it.
I like to break it down. Irregular fibrillatory waves prior to the QRS. I like that. I'm a definition guy, and that's why I like to I'm going to define delta wave. And the reason I'm going to define it this way is when I took a preparatory test for when I was taking, that's distinct.
Mm-hmm.
Yeah, we need to put that there.
Mm-hmm.
Look at that thing. But the reason why I like to define it this way, I was taking a preparatory test when I was studying for my paramedic, and the question was referenced to WPW, and they were asking what would the EKG present with, and the answer was the slurring of the QRS.
Sure, the delta. Right.
Yeah, but it didn't want to give you delta wave.
Right.
They wanted to. They said what would be some of the EKG findings, and the correct answer was slurring of the QRS. I thought that was pretty neat.
Yeah, and it usually, Dr. Weston was the EP guy that I talked to about this pregnant lady, and he was like, yeah, she definitely has it. She's got the short PR interval, this delta wave, and it can go. And I'll show. There's a couple pictures we'll put in there.
So shows, short PR interval is also okay, because I guess I had forgot that,
or so maybe they show this one here about normal conduction, then they show the one for WPW, and I think the answer if you had a test question for medications would be procainamide, although nobody has it. But
my vision's not as good as it was since the tumor started growing.
Oh my God! Shut up.
Can I see?
Yeah.
All right, so we're going to put this one on the screen.
Yeah, a couple different ones.
All right, let's screenshot that really quick because I'll lose it. What else are we going to talk about in the
Brugada.
That's all you, player.
Brugada syndrome is very interesting.
Aaron actually has a thing in his office. It's like this letter from a patient. They were diagnosed with Brugada. It's serious. Have you ever seen that? I think there was an Unsolved Mysteries, and I always wondered if it had to be with Brugada syndrome, where a whole bunch of people in the family just drop dead, and I think it's usually there's some kind of Mediterranean background, but also it's a theme that back in the day before they recognized all these things, they had these early cardiac deaths or these early syncopes or these early things, and they end up getting a defibrillator usually, but how do we identify it? On EKG, there's a Brugada syndrome, genetic disorder that can cause a dangerous, irregular heartbeat. Right. When this happens, lower chambers of the heart the ventricles, they beat fast and irregularly.
Yeah.
This prevents blood from circulating in your body.
Right.
Like, I mean, just all the other things we've
right.
talked about.
I think it's a channelopathy, though, and I think it's genetic, usually.
Does this help you, or would you like something different?
No, this is fine.
Okay.
There are several types, and I still pull these up when I am looking at an EKG with abnormalities or somebody that has syncope. See, so it says signs and symptoms.
That guy, Aaron, syncope.
Yeah, syncope with cardiac arrest. And it can be asymptomatic. Some people get it with AFib, whatever. It doesn't matter. But there's a 12, they do they drug challenge people with a sodium channel blocker in patients with syncope without an obvious cause. And they do a whole bunch of other stuff. There's all these other levels that you can pull. But anyway, on an EKG, which is what you guys would have, there's this weird, like, pronounced sort of J point. I don't know if this is the best. Hang on.
Go back just a little bit. There was some other images. Go to these images here, and you might find something a little bit better.
Yeah.
Right there. I like that. That's even your people. No?
Yeah. So see that it's sudden death is the biggest. I mean, it's a sodium channelopathy. It's usually familial, and they get an ICD-9, and they get put on medicine usually. But you see how there's that weird like J point T way like that. That is the.
Ooh.
That is what you do. Now there is a type 2, but it's not as. This type 1 is the most important one there is.
Does that kind of look like an Osborne wave?
Yes.
Yeah.
Correct.
Yeah. So it kind of same kind of appearance, which is also a significant finding on EKG.
So you guys should look at this because if you get a syncope patient and you see this weird kind of J point elevation where there shouldn't be, you have to consider this. It's very helpful to tell a doctor that too. And I'm like, hey, look at these weird EKG findings that may be significant for Brugada.
Besides rapid transport and identification, is there anything particularly that we need to be doing for these patients?
No, I mean, I do wonder if you should just put them on pads in case,
Oh, yeah. I mean,
you always wonder.
Yeah. I'm a, prophylactic pad patient anyways. When I see these weird arrhythmias or something I just can't distinguish, I'm going to probably go ahead and consider that.
Yeah.
Good stuff. Really good stuff today we've talked about. So we finishing out this whole series, because I guess this would be our final episode where we talk about the EKG nitty gritty. We'll be redoing some of the prior episodes just to make sure they match our format. And then we'll release this 2-part class. What I was thinking, we do sinus and all those that we did before, narrow complex and things like that, and then we come up and have like a part 2. That way it's easier to kind of take in. You don't have, because in the end, it's probably going to be a 2-hour course right here. Yeah. It's very important, though. It's I love EKG. I've learned so much listening to you today, too.
You did?
I did.
About how much you don't want to work with me anymore?
No. I wouldn't work with anybody different.
We're going to give you a plug since you got that award. Tell us about that award.
So the award in the state of South Carolina, I got the Jack Niles Educator of the Year Award. Completely surprised by that. The amount of time that I've been in this job, there's a whole lot more people that, very much smarter than myself that put in. I'm very blessed to be able to have this thing.
It was cool.
Yes, it was good. I really do. I'm blessed. Thank you.
And we do have to give a plug that there was other people in the area too that got awards. Amy Jo West got the Nurse of the Year, and then Anderson County and Steve Kelly got awards also. So it's impressive.
Yes. Yeah, good stuff. We got some good people in the States.
We do.
All right.
All right. See you soon.
See you next time.
Bye.